I would like to express my sincere gratitude to the organizers for their kind invitation and for giving me the opportunity to share this session with such a distinguished audience. I do not have any relevant financial interest, arrangements, or affiliation that would constitute a conflict of interest. Today, I will present and we will talk and explore the physiological principles that are relevant to the thoracic anesthesia. And I will basically emphasize and focus on the respiratory mechanics and heart-lung interaction. Second is the one-lung ventilation. And third is the hypoxic pulmonary vasoconstriction. Now, first of all, we will start from the respiratory mechanics. Here is the awake state and the anesthetized state. This slide compares the awake and anesthetized states. In the awake patient, the normal diaphragmatic tone maintains the functional residual capacity, as you all know, keeping the alveoli open and ensuring the good ventilation perfusion matching. But after the induction of general anesthesia, the respiratory muscle tone is lost, the diaphragm moves upwards due to abdominal pressure, and functional residual capacity falls. As lung volume decreases, the dependent alveoli collapses, producing atelectasis and low ventilation perfusion regions. These changes reduce the lung compliance and oxygen reserve, increasing the risk of hypoxemia. This is particularly important in thoracic anesthesia because you know that the dependent lung becomes the only ventilated lung during one-lung ventilation. Here we will talk about the compliance and elastance. As you all know, that compliance describes how easily the lungs expand, and it is calculated as the change in volume divided by the change in pressure, while the elastance is simply the inverse of the compliance, and it reflects the lung stiffness. As you can see on the left side of this slide, emphysema is an example of the high compliance. These lungs inflate easily but have poor elastic recoil, which can lead to air trapping. While on the right side, you can see the acute respiratory distress syndrome, atelectasis, and fibrosis, which can produce a low compliance. Therefore, high pressure is required to deliver the same tidal volume. During thoracic anesthesia and one-lung ventilation, compliance falls because of the reduced functional residual capacity, diaphragmatic displacement, mediastinal compression. We will discuss it in the further slides that are coming. As a result, the elastance and ventilator pressures increases. Here we will talk about the pulmonary pressure and volume relationships. As you can see on the x-axis represent the transpulmonary pressure, while on the y-axis it represents the lung volumes. As you can see, the blue line curve, which is the normal lung, reflecting the optimal compliance. It shows the normal functional residual capacity and the total lung capacity, while you can see the orange curve as well, which shows the obstructive disease like emphysema. It can lead to loss of elastic recoil, increases compliance, so the lungs inflate easily. But the air trapping can lead to increased FRC and hyperinflation with a higher total lung capacity. Therefore, the graph moves toward the left side of this graph. As you can see on the right side, the green and the red curves, which represent restrictive disease. As the lung becomes progressively stiffer, the pressure volume curve shifts toward the right and becomes flatter, indicating reduced compliance. Therefore, high pressures are needed to achieve the same tidal volume. Right now, the driving pressure is the surrogate for the global lung strains. And it is calculated as the plateau pressure minus PEEP, or alternatively, you can say that the tidal volume divided by the respiratory system compliance. In simple terms, the driving pressure can tell us how much pressure is required to deliver a given tidal volume into the available aerated lung. When compliance decreases because of atelectasis, obesity, one lung ventilation, or lung injury, the driving pressure increases. Most of the studies and numerous studies have shown that the higher driving pressure are associated with increased post-operative pulmonary complication and worsen the outcome. Therefore, we will focus, and this means that the ventilation should not focus solely on a fixed tidal volume, such as 6 ml per kg or 7 ml per kg, but instead make sure that we should aim to optimize the lung recruitment and compliance while keeping the driving pressure as low as possible. Isolating destructive forces and the risk of the intrinsic PEEP is also a very important slide. As you can see the graph, this graph demonstrates how airway pressure can be divided into airway resistance and tissue resistance. During inspiration, pressure rises to the peak airway pressure. When an inspiratory pause is applied, the flow stops and pressure immediately falls to the level of P1. This means that this initial drop represents airway resistance, which means increase due to bronchospasm, either secretion or endotracheal tube obstruction. You can see another steeper decline from P1 to P2, which represent a tissue resistance and the viscoelastic properties of the lungs and chest wall. This also highlights the intrinsic PEEP or autopheep, which develops when exhalation is incomplete due to increased resistance or insufficient expiratory time. Keep in mind three most important things that are related to this slide, that if you have high peak airway pressure and high and normal plateau pressure, you must think about the airway problems like bronchospasm, secretion, and tube kinking. But if you have high peak airway pressure and high plateau pressure, then you must think about the compliance problem. That is atelectasis, one lung ventilations, and pneumothorax. Another is if there is a flow time curve that is not returning to zero, then you must think about the intrinsic PEEP or autopheep. This figure again shows the spectrum of ventilation perfusion relationship. As you can see on the left side is the absolute shunt. The alveoli receives most of the blood flow, but little or no ventilation. Blood, therefore, passes through the lung without being oxygenated. As you all know, during anesthesia, shunt caused by atelectasis is the primary cause of hypoxemia. In the center, you can see the normal unit where ventilation and perfusion are perfectly matched and no mismatch in the middle. But if you can see on the third slide, on the right side, the absolute dead space in this where ventilation is important is present, but perfusion is absent or markedly reduced. So the delivered ventilation does not participate in the gaseous exchange. And as you all know that during anesthesia, both shunt and dead space increases, leading to impaired oxygenation and less efficient carbon dioxide elimination. This spectrum is particularly important during thoracic surgery and one lung ventilation. Now we will talk about the carbon dioxide ventilatory response curve. As you see the orange curve, that is the metabolic hyperbola, which shows the inverse relationship between ventilation and the arterial carbon dioxide pressure. As you can see that as ventilation falls, the arterial carbon dioxide pressure rises and vice versa. As you can see, the blue line is the normal awake response, where even a small rise in PaCO2 would produce a large increase in the ventilation. After an induction of the general anesthesia and the use of opioids, it can progressively shift this response to the right side and flatten the slope. As you see the green, pink, and brown lines, this means that the respiratory centers become less sensitive to carbon dioxide, resulting in reduced minute ventilation and progressively higher resting PaCO2. Again, this graph illustrates the normal distribution of ventilation, perfusion, and V by Q mismatch in the upright lung. Here you can see the blue line represents the pulmonary blood flow, which is greatest at the lung base, because the gravity increases the pulmonary vascular pressure. Remember this point that the gravity increases the pulmonary vascular pressure, and as you can see, the green line represent ventilation, which is also greatest at the base because basal alveoli are more compliant and expand more during inspiration. Keep in mind that perfusion decreases much more rapidly than ventilation we move from as we move toward the apex. As a result, the ventilation perfusion ratio, as shown by the orange line, progressively increases from the base toward the apex. Clinically, keep in mind this thing. This is the normal physiology forms the basis for understanding ventilation perfusion mismatch during lateral position and one lung ventilation that we will discuss in the coming slides. These are the wedge zones of the lungs. In the upright lung, the gravity causes pulmonary blood flow to increase progressively from the apex toward the base. This is the very important point that you all keep in mind. Now, this is the zone 1. Zone 1 is the apex of the lungs, has a little or no blood flow or no flow because alveolar pressure exceeds the vascular pressure. Here, the capillaries collapses and no flow. And zone 2, as you see, the arterial pressure exceeds the alveolar pressure, which exceeds pulmonary venous pressure. So here is the mid lung, and there is the flow is the intermittent flow or water fall flow. Now the zone 3 has a continuous or maximal perfusion because both arterial and venous pressure exceeds the alveolar pressure. Keep in mind that at a very low lung volumes, there is a fourth zone may appear at the extreme of the lung bases. In the fourth zone, increase interstitial pressure compresses the extra alveolar vessel, which further reducing the blood flow despite the region is gravity dependent. Now, in this slide, as you all know, that the heart resides within the thoracic cavity and is directly influenced by the changes in the intrathoracic pressure. In the underlying part of this slide, during spontaneous breathing, negative pleural pressure acts as a suction pump and it enhances the venous return. But in contrast, positive pressure ventilation increases intrathoracic pressure, reducing the venous return and potentially decreasing the cardiac output. This is the fundamental physiological basis of heart-lung interactions. On the most right side of this slide, keep in mind that the right ventricle performs best near the functional residual capacity. And also keep in mind that at very low lung volumes, the extra alveolar vessels collapses. And at a very high lung volume, the alveolar vessels are compressed by over-distended alveoli. The result, both extreme low lung volumes and both extreme high lung volumes can increase the right ventricular afterload. Now the heart-lung interaction during one lung ventilation. During one lung ventilation, hypoxic pulmonary vasoconstriction, we will discuss HPV in the coming slides, but keep in mind that HPV diverts the blood away from the non-ventilated lung, which can reduce the shunt and preserving the oxygenation. But keep in mind as well that HPV also increases the pulmonary vascular resistance and right ventricular afterload. Also, you can see toward the right side of this slide, the clinical implication that excessive PEEP, hyperinflation, hypoxia, hypercarbia can further increase the right ventricular workload. Now we will talk about one lung ventilation, and we will discuss the one lung ventilation into 5 to 6 different scenarios and 5 to 6 different situations. Here, in the awake patient, in awake spontaneously breathing patient, which are placed in the lateral decubitus position, as we have previously talked about, that gravity directs most of the pulmonary blood flow to the dependent lung. At the same time, the dependent hemodiaphragm remains functional and contracts efficiently, that we can see on the ventilation. So the dependent lung receives a larger proportion of the tidal volume, and hence both ventilation and perfusion are preferentially well distributed to the dependent lung. So the end result is ventilation perfusion are matched, is preserved, and oxygenation remains excellent. Here again, we will talk about in the awake patient, which is spontaneously breathing with an open chest. Here is a little bit different scenarios. So keep in mind that inspiration generates more negative pressure in the intact hemithorax than in the open hemithorax. Uh, this pressure difference causes the mediastinum to shift toward the dependent lung, producing the cardiovascular instability. Simultaneously, uh, as air moves between the two lungs rather than between the atmosphere and alveoli, a phenomenon known as the paradoxical respiration or paradoxical breathing. This results in wasted ventilation and impaired gaseous exchange. Keep in mind that positive pressure ventilation abolishes both the mediastinal shift and paradoxical breathing by equalizing the pressure and directing airflow into the lungs. Now we will talk about in the lateral decubitus position again, induction of general anesthesia has little effect on the perfusion. After induction of the general anesthesia, it has a very little effect on the perfusion, which remains preferentially distributed to the dependent lung because of the gravity. But keep in mind that anesthesia markedly alters ventilation. So the dependent hemodiaphragm is displaced separated by the abdominal content mediastinal structure, which compress the dependent lung, and the operating table restrict expansion. So the result, the dependent lungs becomes less compliant and receives less tidal volume, while the non-dependent lung becomes relatively more compliant and receives most of the ventilation. The result is a significant ventilation perfusion mismatch because perfusion continues to favor the dependent lung while ventilation shifts toward the non-dependent lung. Again, in the lateral decubitus position under general anesthesia, but the chest in this slide is open, in this scenario is open, who continues to breathe spontaneously. Keep in mind that opening the chest has little effect on the perfusion because gravity still directs most pulmonary blood flow to the dependent lung. Keep in mind that ventilation changes substantially, as in the previous slide as well, but here is removal of the chest wall constraint increases the compliance of the non-dependent lung, allowing it to expand more easily and receives an even greater proportion of tidal volume. So the dependent lung remains compressed by the abdominal contents as discussed previously, and the ventilation shifts further toward the non-dependent lung, while perfusion remains concentrated in the dependent lung. Again, worsening of the ventilation perfusion mismatch and increasing the risk of hypoxemia. Keep in mind that opening the chest does not significantly change where blood goes, but it markedly increases the ventilation. It markedly increases ventilation of the non-dependent lungs because its compliance increases. Therefore, ventilation perfusion mismatch become worse. As you can see in this, the ventilation perfusion mismatch is worse. Now, this slide shows and this figure illustrates that the effect of paralysis we have given a trachurium, and we have paralyzed the patient. In these scenarios, the effects of paralysis and chest, here is the chest closed, and on the right side it will be the chest will be open, and opening the chest in the lateral position. Keep in mind that perfusion continues to favor the dependent lung because of the gravity. However, paralysis and positive pressure ventilation, the diaphragmatic displacement occurs preferentially toward the non-dependent lung, where the abdominal resistance is least in the closed chest, while opening the chest further increases the compliance of the non-dependent lung, and it results most tidal volumes is directed toward the non-dependent lung, while the dependent lung receives less ventilation despite receiving most of the blood flow. This creates again significantly ventilation perfusion mismatch and increasing the likelihood of hypoxemia. Now, one lung ventilation. Keep in mind that during one lung ventilation, the non-dependent lung is collapsed and not ventilated, and all the ventilation occurs in the dependent lung. Now, here I underline the one slide perfusion before one lung ventilation. It means that during two lung ventilation, most of the blood flow distribution from the cardiac output to the dependent lung is 60%, and toward the non-dependent lung is 40% of the cardiac output. And there is a physiological shunt. Total cardiac output is 10%, 5% of the dependent lung, and 5% of the non-dependent lung. So the net blood participating in gaseous exchange to the dependent lung is 55%, and to the non-dependent lung is 35%. Now, starting of the one lung ventilation with no compensation. It means that no hypoxic pulmonary vasoconstriction is activated. So the non-dependent lung is not ventilated, so all the blood flowing through it becomes an obligatory right to left shunt. So keep in mind that non-dependent lung receive 35% of the blood flow, and keep in mind that 10% is the physiological shunt from the non-dependent lung and 5% from the dependent lung. So in this case, we have a total of 45% physiological shunt. Now we will discuss the compensated form. It means that the effect of the hypoxic pulmonary vasoconstriction, hypoxic HPV diverts most of the blood away from the non-dependent lung, which is hypoxic lung, toward the dependent lung. So HPV can decrease 50% of the blood flow to the non-dependent lung. And as we know that the non-dependent lung receives 35%, so HPV will decrease that 35% by 50%. It means that 17.5% of the blood will be goes to the non-dependent lung, and 17.5% will be shifted toward the dependent lung. And as we all know that 5% is the obligatory physiological shunt of the non-dependent lung. So a total of, in this case, a total of 22.5% blood will be shunted. Again, the total shunt, we will calculate the total shunt. Non-dependent lung shunt is 22.5%, and the dependent lung shunt is 5%. So a total shunt during one lung ventilation is 27.5%. Now here, as you can see, that 27.5% is the shunted blood and 72.5% is the not shunted blood that are shifted toward the dependent lung. So keep in mind that most blood, 72.5%, goes to the dependent lung, will take part in oxygenation, and it is entirely dependent on 72.5%. Oxygenation now entirely depends on the dependent lung. However, keep in mind that anesthesia, paralysis, reduced functional residual capacity, atelectasis, and mediastinal compression can impair the ventilation of the dependent lung, which produces low ventilation perfusion regions and increasing the alveolar arterial oxygen gradient. Now here is the hypoxic pulmonary vasoconstriction is a most important concept. HPV, we will talk about hypoxic pulmonary vasoconstriction. The definition is the This is the physiological reflex of the pulmonary vasculature, whereby the alveolar hypoxia triggers the constriction of the local pulmonary arterioles, which can divert the blood flow from poorly ventilated to a well-ventilated lung regions. As you can see on the left side of the slide is the hypoxic alveoli, which is poorly ventilated. It leads to vasoconstriction. The net and diverting the blood flow to the from the hypoxic region to a well-ventilated oxygenated region, and the net result is decrease in shunt and increase in the oxygenation. This slide is very self-explanatory, as you can see in the state one, where ventilation and perfusion are perfectly balanced in the normal state. But as the induction of anesthesia, the mismatch occur. Anesthesia disrupts the normal ventilation perfusion relationships, impairing the gas exchange and creating inequalities. As you can see to the state 3, where HPV is compensated. So hypoxic pulmonary vasoconstriction redistribute the blood flow from the newly compromised areas to a well-ventilated regions, preserving the arterial oxygenation carrying capacity. Now we will talk about the mechanism of the HPV. As you can see, the track 1 and track 2, the most important is the pulmonary artery smooth muscle cell, which is the prime effectors. The step 1, hypoxia activate the oxygen sensitive ion channel, which further causes the potassium channel are inhibited and causing membrane depolarization. In As you can see on the step 3, the intracellular, the voltage gated L-type calcium channels are activated, and which can lead to increased intracellular calcium level spikes. In the step 4, it will lead to the smooth muscle contract, and it causes vasoconstriction. Hypoxia also alters the release of the vasoactive substances like vasoconstrictor release endothelin 1, thromboxane A2, serotonin, which can intensifying the HPV, while it can also release the vasodilators release like nitric oxide, which can modulate the tone of the HPV. This is a self-explanatory, as you all know that systemic microvasculature in response to a hypoxia, it vasodilates and increase the regional perfusion to a starving tissue. But if we can see to the pulmonary microvasculature, here we can see the opposite phenomena. It can lead to vasoconstriction in response to hypoxia and diversion of the blood to oxygen-rich alveoli. Now the temporal architecture of the hypoxic pulmonary vasoconstriction, it is a time-dependent process rather than a single event. During the acute phase, occurring within minutes, the alveolar hypoxia triggers the potassium channels, inhibiting the calcium influx and vasoconstriction. It can rapidly divert the blood toward the better ventilated alveoli. This is a protective mechanism, and we rely on HPV during one-lung ventilation. If we can see to the sustained transitional phase, it means that if hypoxia persists for more than 30 minutes to several hours, then HPV enter into a sustained phase, maintained phase by the intracellular calcium signaling and increased calcium sensitivity, which producing a stronger and even more stable vasoconstriction. But if we can see to a chronic and pathological state with chronic hypoxia, which lasting from days to weeks, the response becomes pathological with vascular remodeling, medial hypertrophy, and pulmonary hypertension. Therefore, keep in mind that acute HPV is beneficial, where chronic HPV contributes to a disease state. Here again is the acute pace sensor, which can hypoxia can lead to voltage gated sodium channel inhibition. It can lead to membrane depolarization. And this is the calcium effector stage, where the voltage gated hypoxia induced the membrane depolarization, and it opens the L-type voltage gated calcium channel. Also, it can open the transient receptor potential channel 6 and 4, which provide additional calcium entry. This rise in intracellular calcium activates the myosin light chain kinase and calmodulin, which can lead to a tin-myosin interaction and pulmonary vasoconstriction. These are the three hypotheses of the oxygen sensing: the redox hypothesis, the energy hypothesis, and the Ross hypothesis. The redox hypothesis tell us that hypoxia decreases the reactive oxygen species, which level and causes vasoconstriction through inhibition of the potassium channel, while the energy hypothesis tell us that hypoxia shifts the energy production cycle and produces more adenosine monophosphate that increases the intracellular calcium through the sarcoplasmic reticulum. While the Ross hypothesis can tell us hypoxia augments the production of the reactive oxygen species that causes HPV through sarcoplasmic reticulum and increase the release of the calcium. But now we will discuss the chronic phase. The chronic phase after the acute HPV is the protective reflex, as we know, but persistent hypoxia transforms it to a pathological process. After approximately 48 hours of sustained hypoxia, reactive oxygen species increases and it suppresses the expression of the oxygen-sensitive potassium channel, which lead to maintaining of the smooth muscle depolarization and vasoconstriction. Chronic hypoxia also upregulates the zinc transporters, which increases the intracellular zinc and promoting proliferation of the pulmonary artery, smooth muscle, and endothelial cells. These molecular events produce a vascular remodeling and medial hypertrophy. This is the chronic remodeling basically works through the Rho-GTPase pathway. The persistent hypoxia activates the Rho-GTPase pathway, which drives chronic pulmonary vascular remodeling through two complementary pathways, the Rho-A pathway and Rho-B pathway. The Rho-A pathway promotes sustained vasoconstriction by increasing the myosin light chain phosphorylation and calcium sensitization, while the Rho-B pathway stimulates pulmonary artery smooth muscle proliferation and vascular remodeling. Together, these pathways produce a medial hypertrophy and increase pulmonary vascular resistance and pulmonary hypertension. These are the comparison between acute and chronic HPV. These are the factors that modulate hypoxic pulmonary vasoconstriction. On the left side, you can see HPV enhanced by, and on the right side, you can see the HPV is inhibited by these factors. Now, keep in mind that hypoxic pulmonary vasoconstriction in human is a definitive dual-phase physiological reality. It is an elegant acute electrical adaptation that promotes systemic oxygenation. It is also a dangerous when chronic genetic pathology that destroys the right ventricle. We must manage the acute adaptation while preventing the chronic pathology.